Okay, now we're moving on to what are the agents of the renin inhibitors and the angiotensin antagonists. So the first one is the ACE inhibitors, are a class of drugs that block the angiotensin converting enzyme ACE, a key component in the renin angiotensin aldosterone system RAAS. This inhibition prevents the conversion of angiotensin 1 to angiotensin 2, a potent vasoconstrictor, leading to blood pressure reduction and other beneficial effects. Second one is the direct renin inhibitors, which are a class of antihypertensive drugs that act at the top of the renin-angiotensin-aldosterone system, cascade by directly inhibiting renin activity. So this reduces the formation of angiotensin 1 and subsequently angiotensin 2, which are responsible for vasoconstriction and aldosterone secretion. And last one is the angiotensin 2 receptor blockers, which is ARBs, are a class of drugs that selectively block the binding of angiotensin 2 to its angiotensin 1 receptor. And this reduces the effects of angiotensin 2, such as vasoconstriction, aldosterone secretion, and sodium retention, thereby lowering blood pressure and protecting organs from damage caused by high blood pressure and excessive RAAS activation.
So let's explore the mechanism of action for three key medications in the renin-angiotensin system. First is the ACE inhibitors like perindopril and enalapril, which inhibits the ACE to block the conversion of angiotensin 1 to angiotensin 2, which reduces vasoconstriction and lowers aldosterone secretion, ultimately decreasing blood pressure. Second is the ARBs, which are angiotensin 2 receptor blockers, such as losartan, which blocks angiotensin 2 receptors to prevent vasoconstriction and reduce blood pressure effectively. And third is the direct renin inhibitors like aliskiren act by directly inhibiting renin, stopping angiotensinogen from converting to angiotensin 1. Each of these drugs target the renin-angiotensin system differently but achieve the same goal, which is to manage hypertension effectively.
So next, we're moving on to the pharmacokinetic of ilascarine. The first one is the absorption. It is rapidly absorbed following oral administration. However, it have low oral bioavailability, approximately 2.6%, indicating low bioavailability due to the first pass metabolism. For distribution, the binding of ilascarine to plasma protein is moderate, and it is dependent to the drug concentration. For metabolism, the primary route is it is eliminated through the hepatobiliary route as unchanged drug. The second one is via oxidative metabolism, which is minor metabolism occur via cytochrome 3A4 with two major oxidized metabolites accounting for less than 5% of the plasma concentration at peak. For the excretion, the half-life is 24 hours, thus allowing for once daily dosing. It is excreted via biliary or fecal route. Approximately 80% of the aliskiren will remain unchanged in the plasma, indicating low exposure to metabolites. And last one, via the renal excretion, only 0.6% of the dose is recovered in the urine. For pharmacokinetic for angiotensin resin blocker, the absorption, it is well absorbed orally. However, the bioavailability will vary among the agents. For distribution, it is widely distributed with varying degree of plasma protein binding. For metabolism, the primary route is via hepatic, involving cytochrome P4015 enzyme. And for the excretion, the half-life, it is differ among agents, thus influencing the dosing frequency, and it is excreted via the urine and fecal route.
Next, we go to the indication for renin-angiotensin aldosterone modulators. First is hypertension. This medication can effectively lower blood pressure by relaxing blood vessels or reducing the production of hormone that constrict blood vessels. Next is heart failure. Renin-angiotensin aldosterone system will be triggered when heart fails to pump blood efficiently. It then will worsen the condition by increasing fluid retention and stress on the heart. This medication can help by reducing the workload of the heart and improve blood flow. Chronic kidney disease. This medication can help by slowing the progression of kidney damage, especially in people with diabetes, which can help in reducing protein in urine, which is a marker for kidney damage, and lowering blood pressure. And next is diabetic nephropathy. It will help in reducing the pressure in the kidneys filtering unit and slowing the decline in kidney function. Lastly is post-myocardial infarction. Renin-angiotensin aldosterone system can be overworked or overactivated after a heart attack, which can further damage the heart. This medication can help by reducing the risk of future heart events and improve heart function.
Now I'm going to present about the side effect of renin-angiotensin aldosterone system. First of all, it will cause hypertension. It is due to increased blood pressures due to the vessel constrictions, which is mediated by angiotensin 2. Next, secondly, it will cause cardiovascular effects, for example, heart failure. Chronic RLS activations contribute to cardiac remodeling, hypertrophy, and fibrosis, which will worsening the heart failure. Besides, it also will promote atherosclerosis. Angiotensin 2 promote inflammation and oxidative stress, which is contribute to the vascular damage. Thirdly, it will cause kidney damage. Prolonged RAS activations can lead to increased pressure in the glomeruli and causing the kidney injuries and worsening the chronic kidney disease. Fourth, electrolyte imbalance. For example, hyperkalemia. Due to reduced aldosterone due to RAS inhibitors can lead to potassium retentions. Furthermore, hypernatremia. Aldosterone-mediated sodium retention can elevate the sodium level. Lastly, it will also cause fluid retention and edema. Aldosterone-driven the sodium and water retentions can cause swelling, and particularly in conditions in heart failure. So those are the side effects of the RAS. Thank you.